room, all this exercise energy. Oh my God, what could be better? These are my kind of people. So I want to welcome everybody here today. Thank you so much for coming. We so appreciate having you here, and we appreciate everything you do, as I will continue to elaborate on. My name is Lori Morell. I actually sit on the Leaders Council, and you may have seen me on many other occasions. I've been working for Project Healthy Bones now for 12 years, working with Mary Wagner, Anita Van Weingartner, Kathleen Morgan, Margie Bissinger, Star Techner, Sally Fullman. Yay! At my day job, I'm a director of an adult day program, but in my former life, I have an exercise science background, and I was a director of health and wellness. So with that being said, you know, May is National Osteoporosis Month, and we, the Bone Health Organization, the state of New Jersey, and the community want to really take this opportunity to acknowledge and thank you, all the peer leaders, for your tremendous contribution of services to the outreach community for Project Healthy Bones service. You are the visual, you are the physical and educational voice for bone health and osteoporosis for the state of New Jersey. We could not do it without you. You are the tributaries that are making other people healthier, educated. It's you. So there are no words to say thank you again. But I'd like you to know that here I have, just to give you some idea, this is a proclamation from the Governor of New Jersey to thank you for your endless efforts of really sustaining and improving the lives of others, because that is what you do. Good, but here it is. Here's the proclamation. It looks better this way, right? And if you couldn't read it from that distance, well, you have superpowers. You're amazing. And this is from Governor Murphy to celebrate our 25-year anniversary, which again could not be done without your outstanding touch and support. We cannot help thank you enough. And that's for you, because you've really made a difference in other people's lives, and that's what it's about. It's giving back, and maybe one day we'll be funded nationally, and believe me, you all deserve to be funded with that. So today's presentation will enhance your knowledge from a holistic perspective on bone health, postural stability, balance, and various breathing techniques. The goal of this event is to empower you as leaders with new information and vocabulary to elevate your classes and personal enlightenment. We do ask that during this wonderful event that you just refrain from any Q&A, because we'd like to get through the presentation. But we will now turn the program over to the infamous Margie Bissinger. Please welcome Margie.
I don't know if infamous is really the word, but first of all, I love being here with all of you. There's the best energy in this room, and it's just my pleasure to be here. You're just such an incredibly special group of people, and you're doing so much good in this world. So thank you, because we can work state level, but it's you who are really carrying this out and really changing lives every day. So thank you, really from the bottom of my heart. I know all of us, thank you for the work you do. It's very, very special. So today we are so lucky to have our special guest, Dr. Claudia Tomas, with us here today. And I just want to say a few words about Dr. Claudia. So Dr. Claudia, she's a physical therapist, a certified strength and conditioning specialist, and she's the Director of Women's Health at Natural Medicine and Rehabilitation in Somerset, New Jersey, which is so exciting. She's in New Jersey. Dr. Claudia is the first clinician in the United States to be a licensed provider of the Onero program. And what the Onero program is, it was developed by the Bone Clinic in Australia, and it's based on the positive research from clinical studies that were done from the Livermore study showing increases in bone density, reduction in fractures and falls with high intensity strength training and impact. So it's so positive, the research, and they took that to be able to, to create a program for that. So it's just very exciting. And the thing is, though, about the Onera, I think it's important to understand that it's not done in a peer leader situation. It's done under the supervision of trained physical therapists and exercise physiologists. That's it. Other people aren't even allowed to, to do the Onera. You have to go through training and have to have that background. But the good thing is there's the concepts we can take from this. There's so many wonderful things that we can take in terms of alignment, in terms of balance, in terms of just how we're doing the exercises and breathing, that I think you're going to all, is there a question? You can't hear me? Can nobody hear me? Did everybody hear me? I guess this is better? Oh. You don't want me to say the whole thing. People got what I said? Yeah. Okay. Okay. But the point is you can take what you learned from today and you'll be able to use the concepts for yourself and also in your classes. So it's just so exciting. And I personally, after I met Claudia, because Dr. Belinda Beck, who did the research, I had interviewed her and asked, is there anyone in the United States doing this? She goes, there's one person, and she lives in Somerset, New Jersey. I said, you've got to be kidding. So that's how I was first introduced to Claudia. And once I met her, I said, I have to take this program. So I've personally been doing Onera now for, I think it's 6 weeks. And it's so amazing. And Dr. Claudia is just incredible. So you're in for a real treat. So I'm going to turn it over to you, Dr. Claudia. Come on up.
I was just saying it's an honor to be here to share some of the information that I have gathered along the way in my years of clinical experience and the experience that I've had with the Onera program. So it's all coming from my heart and from my clinical experience. We all know it. Our habits shape our lives. Our habits are like small steps. What are they? What we eat, what we think, and what we do. And these small steps, they carve a path in a certain direction. Sometimes that direction is desirable, other times is not. Knowing this, I take time with my patients almost every time, and we sit there and retrace their steps. What were their habits over the last days and weeks and months, and where are they taking them? What is the direction they are going? And most often than not, they are astounded. You see, there is something interesting about this concept. It's difficult to see from the inside. You have to step away. Sometimes you have to have somebody else look at it. So many times I point to the direction that my patients are going, and it's a direction that they don't want to be going towards, a place that maybe they don't want to be in. It's like the summer on the beach, you go in the ocean, and you come out, and you're confused, you're in a different spot, right? Your towel is not there, your friends are up, you drifted, you weren't paying attention. Life can be that way. If we don't pay attention, our habits can take us in a direction that maybe we don't want to go. I do this exercise for myself every few months, just to make sure that my direction matches my mental vision. And I came across a book at the beginning of the year by James Clear. It's called Atomic Habits. Do you know this book?
Oh, yes.
Okay. So James points out here that it doesn't take a lot of effort, which is so encouraging. We don't have to make big New Year's resolutions. What we need to do is 1% improvement every day in our daily habits towards the right direction. So if we apply the 1% change, we'll see about 40% improvement in a year. That's a significant improvement. This is what the upward line on this very simple graph is showing. By contrast, the downward line signifies decline. This is when maybe a habit that is not conducive to good health is repeated, or most often than not is when we're drifting, when we're not paying attention, when our habits take us down a path we don't want to go. Last year, I spent about 6 weeks caring for patients at bedside in hospital through my nursing clinicals. And every time I met patients that had fractures and had poor outcomes, I met them here. At the downward line, that had declined. It wasn't just their bone density. They weren't paying attention to their lifestyle. It was more than just bone density. There was weakness. There was loss of vital capacity. And we'll look at the 3 main categories that are implicated in recovery and long-term independence, not just bone density alone. I recently read a study. Dr. Tom Michaud put a compilation of studies looking at fall risk. And something in that study surprised me. I learned that about a big majority of people over 80 spend about 10 hours a day sitting. You heard of sitting is the new smoking, maybe. This is where we're seeing so much decline, loss of muscle strength. Not only just bone density, muscle strength, our ability to expand our lungs to breathe, right? We're collapsing forward. And then I say this over and over. I think that the American couch is the root of all evil. Is that right?
Yes, it is.
I grew up in a community in Romania. We were an agricultural community, and we didn't have couch. We had wooden stools, and we weren't sitting on them very long. They were very uncomfortable. We always moved. Actually, if you found somebody sitting 10 minutes later, you went to check to see if they were still alive. Gerontologist Bernard Isaacs makes this statement. It takes a child 1 year to acquire independent movement and 10 years to acquire independent mobility, like jumping and hopping on one leg. And he states it takes an older person an instant to lose it. But when and where? When they are here. And I hope that today, if you're not climbing on that upward line, we're starting to do that. We're going to look at the 3 categories that you can start working towards so you can climb that upward line. We know that we can improve at any age in strength. We have studies on 90-year-olds and older. As long as we breathe, we can continue to direct our steps towards the direction of improvement. With this said, I think mindset is super important. I think we have to have a conversation about mindset before we have a conversation about bones. It's important that we look at osteoporosis not necessarily as a disease, but as an intelligent response. What does this mean? Our body has an intelligent design, and it responds to its environment by adapting to certain stimuli. For an example, we know that when the astronauts went in space, they lost bone very quickly. What was missing? Gravity, the gravitational pull, the loading on the bones. These were middle-aged men. They didn't have nutritional deficiencies. They were healthy. But we know that once the loading on the bone was removed, the body responded by absorbing bone very quickly. So the first factor that we're looking at is mechanical loading. How are we doing? How are we loading our bones, and what does that mean? The second factor is chemical stress. What is chemical stress? It has to do with our diets, with the medication that maybe we're taking. That's another stressor where we'll see a response from the bone tissue, sometimes an unfavorable response. And the third category of factors is emotional stress. Did you know this? That long-term uncontrolled stress makes your bones weak? How? How does that happen? How can we have a palpable physiological response from an emotional state? Well, we can have a lecture only on that, but it's the hormone cortisol, the stress hormone, that in long periods of times at high levels will deplete the bone. So osteoporosis is a response to three categories of factors. Mechanical loading, we can group them, otherwise it gets overwhelming, I think. Emotional stress and chemical stress. And this is what we're going to be looking today in this lecture. And you can pick what your category is. Where do you want to start to climb the upward line with a 1% improvement every day? So this is the response that we're seeing. On the right side, you see the bone tissue. That's normal, healthy bone tissue. And on the left, you see that the bone was absorbed. That bone is weaker. Now let's talk about the first category of factors, mechanical loading. I'm fortunate to have lived in two different civilizations, so to speak. I feel like I'm coming from a different world when it comes to what exercise means and how we lived back in Europe in my little community, and then how we live here in terms of what we think about exercise and mechanical loading. But the question always comes is, has osteoporosis always been part of the human experience? And 2019, Cambridge University answered that question. I think we knew the answer. And in an archaeological site, they found a humerus bone, which is the upper arm bone of a female that lived 6,000 years ago. And they ran some bone studies. They compared the bone density of this old bone with the arm of an Olympic rower, 25 years old. And guess what? This bone was stronger. They say by 30%. So we need to ask the question, what was their lifestyle? What were they eating? What were they doing? How are they loading these bones? It turns out that the activities that these women were performing look a lot like those that we performed growing up in my community. So it made sense to me. That's the mechanical loading, pushing, pulling, lifting, carrying their babies. That's changed in the Western world. So then we see an adaptive response from our body. Why is this empowering? Why is this not bad news? Well, it's good news because once we know, we can do something about it. Maybe the Western lifestyle is not like the lifestyle I grew up in, but we can create a setting in which we can apply those movements once we understand what it takes. Here are some pictures from left on where I grew up. And then we have pictures in other communities. We know that there are communities around the world today that although they have low bone density, they don't fracture as often. Their fracture rates are very low. And I'll point to some studies because I dug out a few studies for a while. I looked for them, and I found a couple that were good, and they are worth looking at. What are these activities that are done in these communities? Not walking necessarily. There are movements that are performed by bending the hips, by squatting, by lifting, by climbing. This is straight from where I grew up. I lived a hard life, so that's how we carried and lifted. My mom still lives there. I thought it would be fun to show them. I know this is not something that we do here in America. Right, so we took the load off. We took the baby off our backs and put it in the carriage, right? So we just see a normal adaptation, right? The body responded, right? We took that load and now we have a different response. We have weaker bones as a response. So let's look at the second category of factors, chemical stress. So in this category, we can pile up medications, and I only have the most common ones there. The antacids, right? That's a big category. We see those a lot. What else goes into the chemical category? Our foods. Food is chemistry. Diets that are not rich in nutrients, maybe anti-nutrients, maybe toxins. I find out that this community, I usually do not see anti-nutrients or excessive coffee or smoking. We see more of the other factors. Hormone imbalance, of course, we know this because we see that 10–15% loss at menopause. We'll look a little bit later into how we build bones and how this hormone interplay happens. And now let's look at this third category, emotional stress. I only have a slide here, but we could definitely talk about this for a long time. I'm sure you know, Margie, you probably have guests that had days worth of lectures on stress and cortisol. This is long-term, unmitigated stress, anxiety. You don't know how to manage it. We have rise in the hormone cortisol. Cortisol does two things. It actually inhibits bone buildup and stimulates elimination of calcium through urine. So it works at the both ends when we're looking at bone breakdown. Learning techniques to mitigate stress is super important. So why do we talk about this? For me as a provider, I have a calling to alleviate human suffering the best that I can. So that's my main interest. And surely there's a lot of it. We're seeing 1.5 million osteoporotic fractures a year. And this is data from a couple of years ago. Who is mostly at risk? We see mostly over 65, Caucasian, but we see it in other races as well. I would say that certainly the Western comfort doesn't help here. It seems like we have the highest rates here in the States. And although I've seen different statistics, maybe Japan has higher rates of osteoporosis, but it seems that they have low rates of fracture. So that there is a difference there. That's where our main interest is, in fracture prevention. Most of you became aware of this diagnosis at some point when you had a bone density scan. So right now, the gold standard in, I think around the world, in the States for sure, is the DEXA scan. What do we measure through a DEXA scan? X-ray radiation goes through the bone, and depending on the density that it meets, it will generate a report, and you will see two types of scores. A T-score, and the T-score compares your bones with a healthy 30-year-old bone. That's the T-score, and that's the criteria for diagnosis. and then you get a Z-score. And the Z-score compares you with somebody the same age and sex as you. But the diagnosis is based on the T-score. And in statistics, we're looking at something called standard deviation, how far away your scores are from that healthy bone of that 30-year-old. So 2.5 deviations away, the diagnosis is osteoporosis. We've known this for a long time, though, that the DEXA has limitations, and we had concerns with these scores. Why? Mainly because we know that it only predicts about 40% of the fractures. That's not very good. So Cleveland Clinic came with a statement in 2021 describing some of these limitations. Certainly, bone strength. Bone density doesn't equal bone strength. Bone strength is the combination of density and quality. And most of the times with the DEXA scan, we don't measure quality unless a trabecular bone score is ordered. Most of the times we don't see those. So there are some limitations there. I recently read something that came out from Johns Hopkins, a doctor that had her patients take a DEXA scan and then had them sit in a room for an hour. Have you seen this, Margie? And then they redid it, and she got different scores. So why am I bringing this up? Because many times we hang our heads on these scores. And I want to point out that we have to have a way wider vision when we're looking at fracture prevention. So why are they comparing you with a 30-year-old bone? Well, because this is how we build bone. If you're looking at the bone building curve, you see that right about mid-30s, we build our peak. That's our peak bone density for a female. And then you see the male up top. They have higher bone density. A couple of factors there. They have what? Testosterone and more. What's the difference? More muscle. Muscle, that's why we want to build the muscle. Muscle and bone, they are correlated. When we lose muscle, we lose bone. We always see them go hand in hand. That's where our prevention and reversing happens, where we're starting to build some muscle, and I'll show you some studies on how we look at that. But what's important to point here, in that period from 0 to 25, most important window, usually it's where we see the most nutritional deficiencies. How do our kids eat? Our son is graduating from dental school, and he's interested in pursuing holistic dentistry, and we had a very interesting conversation on wisdom teeth and why our jaws are not big enough to fit our teeth anymore. And he pointed out to the deficiencies in utero when the mom is pregnant, and there are nutritional deficiencies there. And he said that's where the dentist has to have the conversation with the mom about nutrition. That's where we have to look. We developed smaller jaws due to these nutritional deficiencies from utero through childhood. Just very interesting way to look at it. So our jaws are bones, our teeth are bones. Where do we see, when can we spot the first issues with our bones? In childhood, really, when we see what? Tooth decay. Those are our first signs that we need to intervene nutritionally with lifestyle. And then what happens? 50s and 60s, we see the decline, usually due to decreased estrogenic activity. we see that 15% decline in bone density. Another thing worth mentioning here for the female, during that peak building period, is that that's where we see the most concerns in terms of medication too, including birth control, right? That's a medication that disrupts our hormones. Osteoporosis can also be secondary to other diseases, and I'm just putting them here to mention them. Usually, they are hormonal disorders also. They are endocrine disorders. Thyroid, diabetes, right? Diabetes is a big one. Bone marrow disorders, immobilization, like the patient that's laying down for a long period of time due to disease or sickness. We see bone loss there. Other causes that are related to chemical stress, right? We don't absorb nutrients. Gastrointestinal disorders. And some of the medications that I mentioned before. So what do we see? Is it possible that we can prevent osteoporosis? When should we intervene? Well, very early. But for me as a provider, although we don't rarely see these DEXA scans early, we usually see them around menopause, and I really don't like that they are called preventative tests. Because what are they preventing? You're just learning that you have osteoporosis at that time. They should be done in mid-30s, maybe even earlier, right? So we can do prevention there. But for me as a clinician, the first things, the first signs are here in my patient's presentation. How do they look? What am I looking for? Muscle loss, weakness. And how does that present in their posture, their postural presentation? So we can identify this problem early and start building muscle, improving the posture. Let's look at the left picture here. We have the lady on the left, that's normal posture. And then we see the middle one. I like how you're all adjusting your posture right now. I love it. So the middle one has drifted a little bit, right? Nobody plans to be there. Remember the first thing I was telling you about our daily habits? None of us plan to be there. It happens. We're drifting, we're not paying attention. The good news is that at any stage, we can make some changes. That's the beauty of the human body. It's not going to be perfect if you're in that third stage, but we can still make some changes, and we have some research that shows that. So why is this important? Why is this postural alignment so important? Well, let's look. On the left, on the right side, we have the skeleton, the skeletal presentation there. When our body collapses forward and our head shifts anteriorly, there is a bigger concern than just the look alone of this posture. What is inside our rib cage? Lungs, heart. What happens there with the postural collapse? Our vital capacity is impacted. Remember when I was telling you I was meeting patients in the hospital, they didn't have good outcomes. That's what has happened. It wasn't the fracture alone. They had lost their ability to recover because of the impairment in the vital capacity. They weren't able to expand their lungs and clear secretions. So we see the loss of life there because of respiratory, not because of the fracture. That's why we have to work at the posture first. It's so important to maintain the vital capacity, because if we have a healthy vent, we have the resources to recover from it. So maintaining that alignment to allow the lungs to expand and maintain vital capacity is super important. When our head is forward, another thing happens. Our airway collapses. You heard of sleep apnea? I worked with a holistic dentist for a few years, and all I was doing was bringing her patients' heads back. And she was doing these really cool scans, and we would see the airway opening, their sleep apnea resolving. Very important. What is inside the spinal cord? The spinal skeleton. I told you the answer. The spinal cord, the central nervous system, the spinal cord attaches to the brain. Look at the amount of traction on that system here. Traction onto the brain, right? We're seeing neurological issues there, pain, suffering. And looking down to the abdomen, when the rib cage collapses, the gastrointestinal system, our intestines don't have room in here any longer, so they protrude anteriorly. That patient didn't gain weight. Her belly shifted forward because there's no room. There's also stress downward into the bladder and bowel. So we're seeing concerns in incontinence. So you see the ramifications of this postural collapse and how important it is to address it early. And when we're seeing those changes, to address them anyway. At any point, we're seeing benefits when we're addressing it. We're going to take a look today at the end of the lecture. I'll give you some pointers on how to assess yourselves and how to make those shifts, those changes, a couple of exercises. Very simple but powerful. None of this information is very exotic. It's just very simple, very doable. So we know these statistics. But again, I want to emphasize, why do we see these poor outcomes? It's so important, and it dawned on me only when I went in a hospital at the bedside in my nursing clinicals. That's when I saw the devastation, and I realized it's not related only to bone density. This patient was sliding down that decline line for a long time, and no one talked to them about it. They didn't know. They were drifting. They weren't paying attention, and yet no one was talking to them about it. When I was at that bedside with those patients, it broke my heart. There was not much I could do. But here is where we do prevention. Here is where you can decide to climb that upward line. Now you learn these things. Now I feel I can make an impact. How do these fractures look? It's usually the anterior part of the spine or the vertebral bodies that kind of collapse onto each other. And then once again, the mechanism of fracture is so important because it's something that you can spot. It's always flexion. It's always bending forward. This is why we need you upright. The mechanism of fracture in the spine is flexion, forward movement. You heard the patients fracturing when they sneeze or when they cough. Why? How'd you? Right? We do some training in our practice, teaching people how to cough and sneeze, believe it or not, and staying upright, right? Or like imploding, right? You hold the sneeze. Little things, but I'm sure your doctor told you, right? That her patients fracture when they sneezed or they coughed. It's not a small thing, it can be impactful, but you can learn how to manipulate that. usually a cough or a sneeze is never a surprise. You know it's going to happen, so you can prepare for it. You can prepare to where you're going to be with your body and your posture. The hip fracture is usually on a side fall. And the most vulnerable part is the femoral neck, although we'll see the fractures in other areas too, but the most common is the neck of the femur. I looked at some studies on this, and we're seeing that those very communities that perform those movements that I told you, in which the hip is bending, we're seeing something happening in the femoral neck. And we saw that with the studies in Oniro too. And that made me excited, because that's an area really difficult to improve. And with those movements, we don't necessarily see improvement in bone density, but we see reorganization of the collagen fibers, which is not density, but it's resilience. And that explains why those communities that perform those movements day in and day out have low bone density but don't fracture. So this is an older study, but nevertheless is powerful. We're looking at T-scores. If you remember, we talked about the T-scores to diagnose osteoporosis, and at minus 2.5 we get the diagnosis. But look what's happening here. We see an increased risk in fracture as the person ages with the same T-scores. Why? If the T-scores are the same in the 80-year-old and in the 50-year-old, why is there a high risk of fracture in the 80-year-old? Say louder. Muscle. That's the good news. Right? That's where we can change. Right? Muscle mass, she has something called sarcopenia. She lost her muscle. It's a lot on the screen. I'll explain to you. This just excited me. One of the studies is very old, but there's really nothing else that I could find. I was just looking for something that would match the community I grew up in, because those women weren't getting bone density scores. I just know they didn't fracture. I thought that they had good bone density, but it turns out that they don't. They all lose bone, but why don't they fracture? Same thing, the activities that they are doing. Climbing, lifting, squatting, pushing, pulling. They maintain the muscle, they maintain these activities. And here's another good one. This is a new study. You know what they studied? They studied these muscles. Look how beautifully they adorn the skeleton. They are called multifidi. So the researchers looked at the cross-section of these muscles. And what they noted was that in people that they found that these muscles were weak, atrophied, and infiltrated with fat, that's what happens. If we don't exercise these muscles, they become fat infiltrated. Same thing we saw in terms of fracture risk. At the same bone density scores, people that had stronger multifidi had lower risk of fracture, or they didn't fracture at all. That makes sense, right? They support the spine, they support the skeleton. How do we work those muscles? Well, first and foremost, we need to make ourselves upright. That's what they do. When we're here, they become lengthened and weak. Exercises like you have in your programs, like the sit to stand, you have that exercise, right? It's being upright and pushing through the hips upright. That stimulates those muscles. So we're seeing again and again that bone density is just one factor of many. And my job as a clinician is to arm my patient from every direction: mechanical stress, emotional stress, chemical stress, muscle strength. And even if they have that event, then they have the resources to bounce back. In 2004, the Surgeon General agreed with us that nutrition, lifestyle, and activity, which is lifestyle changes, should be prescribed first for patients with osteoporosis. That's the holistic approach. That's what we've been talking about. Mechanical loading, chemical stress, emotional stress. They agree. I think when we go in doctor's offices, we don't see this very often, but that's the agreement. That's the first intervention, and it makes sense. So how does this look? How do you address these lifestyle factors? Well, it can look like this, like a mess, right? And this is why I like those categories. I like to put things in categories because it gives me clarity in what am I going to work with that patient. What is the most important thing for them? Because maybe your bone health looks like this, but you have to categorize and see what's the most important thing for you. Where are you going to address the 1% change every day? Maybe it's nutrition, maybe it's exercise, maybe you're sitting too long. You name it, you got the point. So going back once again to treatment, what does lifestyle look like? Once again, we're working on the 3 categories of factors. When we're looking at chemical stress, we're looking at nutrition. Are we getting enough nutrients? Is my patient eating enough? Are they absorbing? Do they have a gastrointestinal disorder? Are they taking a medication that's preventing them from absorbing nutrients? And we're looking at exercise. How much time do they spend sitting? How much time do they spend exercising? We trace those steps with them, and that points us to direction. Where are they going? And it's really mind-opening. And then mental outlook, the stress, how we look at life, that emotional stress. I'm going to touch upon these factors a little bit. We could have an hour lecture or more on each one of them, but we're going to touch on them just a bit with a couple of slides. So generally, what do we want to see on the patient's plate? We want to see about half of the plate with what? With vegetables, and vegetable variety, if possible. Variety, right? If you just do broccoli and cauliflower, maybe you want to challenge yourself. You know, go wild and add some asparagus, right? But variety turns out that the body loves this and it loves to absorb these nutrients from foods. A good quality protein and some healthy fats. So simple. How can this look? You can make a soup. You can throw a bunch of vegetables there and put some bone broth, and you have it for 3 days. What I'm saying is that none of this is exotic. This is stuff that we can all do. If we make that self-assessment like I talked about at the beginning, just asking yourself, okay, where am I going with my nutrition? Let me step back and look. How have I been eating the last week, the last month? Am I going the right direction here? And then go in and make one of these soups. Or another one, you can just chop up vegetables and bake them. See what you have in the fridge. Challenge yourself to get a couple more. And then you can have it for a few days. How about exercise? Well, I think I'm preaching to the choir now. I know you're all exercising. You're in this amazing program here. But we know that exercise is not only important for the bone. Exercise is important for all those factors that allow you to recover from a health event. And that's my interest as a provider. I don't work with bones, I work with people. We need to look at the whole person. I want my patient to be able to recover from anything, pneumonia, respiratory infection. That's my job, to build them up so they can do that. But what we see, once again, the couch emerges. What happens? 47% of the bone mass will lose if we're a couch potato. Men lose about 30%. Muscle strength, again, they go hand in hand, muscle strength and bone loss. And when I work with my patients, the first thing that I need to see is muscle strength. I know when they build strength, okay, we're out of the woods here. They are stronger, that's good. Their posture is better, okay. And I'm constantly monitoring this. That's what I don't need a lot of scans. I need to look at that person. We need to look at them. How are they standing? How are they sitting? Are they able to stand up from a chair freely? Do they need to push with their hands? Can they climb the stairs without pulling with their arms for dear life? That's decline. All those can be reversed. So what do we see with exercise? Fear, right? A lot of fear. We know that those communities around the world that don't fracture, they move around, they climb, they squat, they carry heavy loads, and this is exactly what we don't do here. That's why we have to be in a setting in which we're guided. But we know that when we're looking at bone density alone and how we build it, the loads have to be heavier. But if you're in a setting like this, what's going to be important for you are those factors. Do you stand more upright? Are you stronger? Are you able to come off the seat independently? Those are the factors that are going to matter in the long term when we're looking at fracture risk. You know this, I think you all know this. You were taught the flexion, right? The flexion mechanism. All the exercises, your activities around the house, how you pick up stuff off the floor, should be away from that flexion moment, from bending the spine forward. So we're avoiding crunches, and we try to keep the hip mobility so we can lunge down, so we can squat down to maintain the spine upright. What should exercise do? Build good posture, strong muscles, keep you upright, improve your vital capacity, your ability to take air in your lungs and expand it. Vital capacity studies, there are many of them, they are correlated with mortality and morbidity for the reason that I explained before. It reduces our ability to recover. Our lungs are important. We need that space. We need that exercise. I'll touch upon at the end on an exercise that you can do. We do this fun program in our office, and we're looking, the computer kind of undresses the muscles and looks at the skeleton. But you don't need anything fancy, really. I'll show you how to look and analyze even yourself. We'll look at a few body landmarks that we can look, and then you can understand how to align your posture. Another interesting study looks at ability to stand on one leg for 10 seconds in relationship with mortality. Very interesting. They looked at patients that weren't able to maintain a single leg stance for 10 seconds, and we saw increased mortality in the next 6 years. I think that should be something that every primary care provider should screen and should send that patient to get stronger. What is balance a result of? Strength, right? Mobility, inner ear, vestibular, right? Some of you have that experience. But strength is a big factor, and the ability to stand on one leg is something that we can reverse. Why do we see the inability to stand on one leg? Weakness, usually. How can you test this on your own safely? Stand by your kitchen counter and hold with your hands right there and test yourself if you want. But I also know you are doing some exercises here, standing on one leg and leg lifts and stuff like that. Those have you stand on the leg, like unilateral, is that right? Yeah, those are great. And some of you have discomfort with them and you maybe want to push through to build it. So what are the areas of focus if we're wrapping it up before the exercise session? We're looking again at those three categories. Mechanical stress with exercise, how much we're sitting, how much we're moving, how much we're loading our bones, our muscle strength, our posture. Chemical stress through our diets, medications that we may be taking. And emotional stress. The cortisol levels and how we mitigate that. So where do we begin? Usually, in our practice, we begin with a postural assessment. And the postural assessment is not just for me, it's for the patient as well. They have to get educated to learn what good posture looks for them, and then they can self-assess. If I have somebody that wants to volunteer, I'll show you the landmarks. Who's my volunteer? You're my volunteer? Okay. Okay. So when we look at posture, we look at the person from the side, and then we look at the person from the front. So when we're looking to the side, what's your name? Ninetta. I will take her hair off her ear, and we're going to look at the earlobe. So those are my landmarks from the top. And then we're looking at her shoulder. And we want to see the earlobe falling above the shoulder. So she fixed her posture here. She looks pretty good. You know, you want to, if you're assessing, you never want to tell the patient what you're doing because then they are fixing it.
So my shoulder went down though.
Yeah, no, okay. You have a little bit of work to do, so that's okay. So we're looking at what the lobe of the ear from the profile, the shoulder. This is called the acromion. Then we're looking at her hip, the side of her hip. You okay if I put my hand on? The side of her hips, her knee, and her ankle if she's standing. And I usually look to see an alignment there. Most commonly, we'll see the earlobe falling a little bit before the shoulder in front of it, like you're seeing here for Ninetta. Very little bit. She's not perfect.
She made adjustment.
She just learned she's not perfect. So, how do we fix that? How do we fix the head position, right? We don't want the head to go forward. Then it takes the back with it, right? So we're seeing this flexion happening, right? This anterior collapse. So what I'm going to tell Ninetta to do is to put her index finger on her chin and her thumb on her sternum. So like this. Now I'm going to ask her to move her chin away from her index fingers and back. Not your finger, your chin. So we're here.
Oh.
Okay. Can we practice this? Yeah. Yes. This is called a chin retraction. So it brings the head back and positions it over the shoulder. So let me see you guys. So the index finger is on your chin and your thumb is on your sternum. Now, how are we going to breathe while we do this? How are we going to breathe? Okay, so here's how we breathe. We take a breath in right here before we move. And then on the breath out, we go ahead and push the head back. When you return from this movement, don't go back here. We try to go back to neutral. We never want to go back into the forward posture head, into the anterior head posture. So we want to take our head from here and position it up over our shoulders. Let me see you in the neck one more time. So just bring the chin down a little bit. Yeah. And there she goes. Are you able to perform this? Can we all stand and do it? Standing? The posture changes as we stand. So now here we are. So you see my profile? I take my breath in right here before I move. And then on the breath out, I retract the chin. You can hold it there for 3 seconds. And then just relax it. Don't return it back to here. Now that we're standing, let's look at another part of us. I'll give you another pointer. This is the sternum right here. When we're collapsing anteriorly, the sternum starts pointing downward. So we want the sternum to come upward. You can move, I think, right? And now we're starting. Breath in. And on the breath out, we're returning the chin. In this position, with the sternum upward, is the best position for our breathing muscle to work. What is our breathing muscle? The diaphragm. The diaphragm. Where is the diaphragm? At the bottom of our ribs. If you put your hands at the bottom of your ribs, and now we're maintaining this upright posture where the diaphragm will work best. And take a breath in, and you want to feel that this area is expanding as you breathe in. If it's difficult to do that, put a hand on your chest and a hand on your belly. And what you want to feel is that when you take a breath in, what moves? Your chest, your diaphragm, your belly. So in order to use your diaphragm for diaphragmatic breathing, which is the most effective way of breathing, you want to feel the hand on your belly moving and the hand on your chest being kind of static. You'll have a little bit of chest movement too, but for diaphragmatic breath, we want to see expansion in the belly. So one hand on the chest, one hand on the belly. You got it, Nina? Okay, go ahead. So breath in. Are you able to do it? Yes? The diaphragm is a rather large muscle. You see there at the bottom is it's like an umbrella at the bottom of our ribs. To maintain vital capacity, our ability to expand our lungs, the diaphragm has to be working and has to be strong. So diaphragmatic breathing is an exercise that you can practice. If it's difficult for you to do it standing, you can lay down at home and have a hand on your chest and a hand on your belly and practice that way. It may be easier to start laying down. You can practice it in sitting. But before you do that, you want to position yourself to where the diaphragm can work. What is the position the diaphragm will be restricted? Forward. Every time we're forward, it will be restricted. Check yourself in the car when you're driving. Put your mirror up a little higher, maybe. It will make you lengthen through your spine. It will make your chin go back so you can look in the back mirror. That's a trick. The seat upward, or practice active sitting upright. Here is something called the cogwheel model. Sometimes patients understand this better if I present this picture to them. Just imagine that your spine is a bunch of cogwheels and you want to return them to their initial position. Sometimes that's easier for the patient to understand. I want to talk a little bit about something called upper cross syndrome. There's also a lower cross syndrome, but we'll look at the upper cross syndrome today. So the forward head posture creates lengthening of the muscles in front of our neck, the neck flexors. You see in that left picture. It also creates tightening of the muscles in the back of our necks, the neck extensors. So when a muscle is lengthened, such as in this posture, it gets weaker. So the weaker it gets, the more difficult it is to maintain the upright posture. So postural alignment doesn't only require awareness, it also requires endurance. Because you may find yourself correcting this, and then a couple of minutes later you're not able to maintain it. What happened? Those muscles did not have endurance. On your seats or in your bags, you have a band, an elastic band. If I may, let me see if I have one. Not, I have to borrow one from you guys. Yeah. You know, I'll borrow Margie's because she knows these exercises. So now we learned how to make the correction. But how do we maintain that correction? How are we able to stand here or sit here for longer periods of time, not to lose the head return? Because you've experienced this, right? So in order to do so, now we need to build endurance in that musculature. So the exercise band is something that you can use. I'm going to change the microphone so I can show you. The band is positioned behind on the occiput in the back of your head. The hands are pulling in the front. And now you are going to go ahead and make that correction that you made with a finger and thumb. You're going to retract the head back, hold there 3 seconds, and then release and relax. You see, I'm not going forward. I'm just staying to neutral. Are you able to do this exercise?
Yes.
Yes?
Yes.
So that's a chin retraction with resistance.
That's great.
So in order To maintain the upright posture, we need awareness. We need to know where the head needs to be positioned, but that's not enough. We need to build endurance. This is here for you to build endurance. You can start with a set of 10 repetitions. Put this on your kitchen counter so you see it. Start every day. You're gonna look at the profile of in a mirror. Look at the earlobe, or you can even feel where the earlobe goes. You can check yourself and retract, and then you can take the band and work starting with 10 repetitions. You should not have pain with this exercise. Do it gentle, and don't do more than 10 to start. I took Pat with me. I know it's not super clear. We're gonna look at the Brugger's exercise.
Are the resistant bands latex?
We have a latex-free that I'll give you. Yeah. They may be latex-free, I had to ask. I'm pretty sure. They may be, yeah.
They're latex-free?
I'm not sure, I have to ask. Don't take it if you're allergic. Pat usually teaches this part, so I took her with me in a picture. We're gonna learn the Brugger's exercise, the Brugger's posture corrective exercise. So the way this is done, you can do it in sitting or standing. I may be able to use this. Now, who can volunteer for this?
Sure.
Okay. Face everyone. So we need to see this from the front. So now you know a little bit about postural alignment. So you can just go ahead and align the head the best that you can. Beautiful. The first step for the Brugger's posture corrective exercise, you're gonna have the hands on the side, and we're gonna spread the fingers. If you cannot do it sitting, you can stand. The first movement is dropping the hands towards the feet, so you can feel a gentle stretch here in your upper traps. Those are your stress muscles, I'm sure you know. So Lori is pressing down towards her feet, that's step one. The second step is turning the palms to open the shoulders. So what are we looking to correct here? The shoulder anteriorly, the forward shoulder, right? So we're upright, we're dropping down, we're correcting this, right? Most of us walk like this. So we're having the hands on the arms aligned on the side, the fingers spread out. The first thing that we do is we're lengthening these stress muscles. The second, we're bringing that shoulder back to open it. How do we breathe here? We take a breath before we start. So nice diaphragmatic breath. And then you return. So we move on a breath out. We breathe in when we're static before we start the exercise. Let me see you, Lori. Here's another representation of the diaphragmatic breathing. When we are breathing in with our diaphragm, you see there on the left, our belly moves forward. So when you have the hand on the belly and on the chest, you'll feel that the hand on the belly moves. You see on the representation on the left. And then when we breathe out, the diaphragm elevates and our belly goes back. I have one more exercise for you with the bands. Another postural exercise. I need another volunteer.
Hindi mo na sa iba para makakuha ka ng
Okay, just watch your step. Okay. Okay. So John, for this exercise, we're gonna have the palms up. So before we move, just make yourself nice and upright. So how do you make that correction? Try the chin. In this exercise, we're going to engage a few of the postural muscles. And by remaining upright, we're engaging those muscles that I show you in that picture, the multifidi, that support the spine. So Joan is holding the band with the palms up. She finds neutral posture, so returns the ear over the shoulder. She takes her breath in right here. And then on the breath out, she stretches the band, moves the arms away from each other, and engages the muscles in her, between her shoulder blades. Turn with the back, Joan, so they can see you. So go ahead and take your breath right here. Good. Now she breathes out, pulls in the band, and engages. You see how her shoulder blades move towards each other? So what are we correcting here? Right? The forward flexion. So on a breath out, we move and engage the muscles into our mid-back. Thank you. Good job. So there's another use for your band. Let me see if I
Do you have a name for that exercise, Doctor?
You can call it shoulder retraction. I brought this with me. If any of you went in hospital at any point, you know what this is.
Right.
Okay. This is an incentive spirometer. So we use it a lot in nursing to prevent pneumonia. It's also an exerciser for your diaphragm. I use it with my 14-year-old daughter who's an athlete to strengthen her diaphragm. This is easy to get. Your provider, your PCP can get you for free, or you can, it's like a $12 thing on Amazon or something like that. If you purchase one and you want to know how to use it, let Sally know and I'll make a video for you on how to exercise your diaphragm with the incentive spirometer. I don't think we should wait until the patient is in hospital to strengthen their diaphragm. Do you agree? We should start young and early. It's an amazing exercise. I use it myself, and I use it for my kids. Once you have it, I'll make a video for you, and you can use it. Use it daily. Incentive spirometer. I think that's all I had. Sally, do you have time for questions? Okay, Sally's telling me when it's done, so I'm listening. Okay, yes.
During the last exercise, were you having your rib cage with your elbows, or you don't even, or if you just only focus on this part, like, you know what I'm saying?
Yeah, on all the, I think I do. Let me know if I answer your question. On every exercise, you are first going to set yourself up in neutral posture before you start. What is that? What I showed at the beginning. The ear is above the shoulder. The best that you can. Some of you may have deformity already, and you may not be able to go there. You're going to go to where you can. There's still a huge benefit, even if you cannot go back to neutral, or how my model was able to go back. It still has a huge benefit to you if you attempt it and you do the best you can. So we always maintain that neutral. We find that neutral posture where the ear is above the shoulder is above the hip is above the knee if we're standing. We take our breath in before we move, and then on the breath out, we engage the diaphragm. We go between our shoulder blades. No matter what the exercise, the principle is the same. If you understand it, that we need to stay within that postural alignment. The goal is always with these exercises to return the patient the best we can to the upright and to prevent anterior collapse or forward movement, the kyphosis, the head forward. That's the goal. Yes?
You had the slide with you had 3 spines, that the one that was straight, the one that was a little bit forward, and then of course the one that was all the way forward, correct? Yeah, go to that so everyone understands.
That was it.
Go back, one more. Forward. That one.
Okay.
Question. I do notice in my aging process here that my stomach is expanding, and I think I have beautiful posture. Evidently, I don't. Is it the back muscle that we were just doing that will help, or is this stomach muscle?
There is a combination of things. There's more to it for sure. And I agonized over what exercise to show you because it's very difficult to show exercises in a big setting like this where I cannot correct you. The engagement of the abdominal muscles, I usually teach it hands-on with the patient one-to-one because it does get a little complex. I was looking for exercises that were teachable in this setting and you could still get the concept of the upright. But yes, it is a combination of things when we're looking at the abdominals. Yeah. I'll talk to you after. We have yeah.
So do you target the transverse abdominis then?
Yeah. Always yeah. Yeah.
You know what might be helpful? Because in Hashimoto's bones, basically they count and they're just so worried that people aren't holding their breath. Just explain the breathing, because I think the breathing is something so wonderful about doing both motions on the exhale, and then you have to stop in the middle.
Is there a specific exercise I should talk about on how to do it with the breath, or do you struggle with?
Is there one plus one?
The concept is the same for all of them. Well, first of all, we never hold the breath, right? The diaphragm's constantly moving, right? So now you got the concept that you want the diaphragm to be engaged during exercise. It's a more effective way of breathing.
You can do it on the one you did, because that's one of their exercises.
Yes.
Just explain the head one in detail about the breathing again.
Every time we're static, meaning that we're not moving. So this is my beginning of my exercise, for example, for this exercise. This is where I will inhale. And then when I move, this is where I exhale. Now, why am I synchronizing this? It's a sequence. Because the transversus abdominis, which is the muscle that braces you, works when we're breathing out. Okay, so we're breathing out and provides an opportunity for that muscle to engage. The muscle that braces our bellies. So breath in here. Breath out through the movement. So we always breathe when we're moving, we're breathing out, and we're breathing in when we're static. Did I explain that well? Yes.
I realize that it's mainly muscle that we're interested in relation to weight. Is there any formula for optimum weight versus height?
For optimal weight, like BMI?
No, because the BMI is something different.
Yeah.
But in relation to osteoporosis, is there any formula?
Honestly, nothing that it's BMI is weight and height. That's how we get it.
There's something that your weight and your height for osteoporosis.
Yeah, I see what you're asking. I don't think there is a formula that's optimal. I think that the way I see it as a clinician, what's optimal for my patient is that they maintain these specific things that we talked about: postural alignment, muscle strength. I don't really go for BMI much, although sometimes we look at something called body composition to see how much muscle they have. And we usually not preoccupied much with weight. My preoccupation is to maintain my patient independent for the rest of their lives. And that has to do with movement, strength, posture, ability to recover from health events. And that's my focus always. Yes?
I just had 2 medical comments related to the belly fat. You alluded that it's a much more complicated issue.
We didn't talk about belly fat. We talked about a muscle here.
Well, it may not be only muscle that she's talking about.
Sure.
So it's important to look at other medical
Of course. My goodness. You have to, again, I have to, that's why I said it's a one-to-one thing. I need to see what that patient looks like. We need to spend the time.
So it's important to look at the whole picture. And then the weight thing, we know that people below 124 pounds have a higher risk.
Sure.
So it's just a risk factor. It's not like an ideal weight.
Yes, that's why I don't really hang my head on it.
So muscle's going to weigh more anyway.
Muscle weighs more than fat anyway, so BMI
Yes,
doesn't
when,
really-
again, I'm never really preoccupied with people's weight.
Right.
You stated that Caucasian women were more likely to be susceptible. Are there any genetic markers that would give you that information or other?
No, I just do the statistics from the CDC, really. It's not something that
There's no ethnic group that,
the data just shows that it's more prevalent, that's all.
but it doesn't explain region, history, or anything like that.
Maybe it does. I didn't really look into that in much depth. Yeah.
The VHOF has a Milliman report that has it by state and by races also in terms of the
Yeah.
psychosis.
I just take the patients that come to me and take care of them. So I don't look much at statistics in other ways. I just want to make them better. Yeah.
For us,
I will send a video if you get the.
I have one of those, and I want
You'll get the video from Sally. It's just hard to demonstrate here because you're not gonna see, and I'm afraid it's just gonna frustrate you. I'll make a video, and Sally will share with you if you have it. I promise. This way, I'll explain by steps. I'll demonstrate. It will be better. Yeah.
Yeah. On the head tall, I was trained to hold my neck, push it back.
Yeah.
Is that almost the same as like doing it this way?
It seems like it's the same, yeah. There's various ways to teach, and sometimes we find some methods are easier for the patient to understand, so we'll use them, but maybe you learn differently, it's the same thing. The goal is to return the best that we can to that upright posture. Time out. She said, I'm done.
I think we need to give her an outstanding amount of applause for the information she shared with us today. Thank you so much, Claudia. It was such a valuable hour and a half. We will have a lot to take away today, and hopefully that you learned a lot of new vernacular and ways that you can share in your Healthy Bones class. I just want to also say we gave you a folder with some amazing handouts for you to share with your classes. So you can look through them, and there is a lovely handout that Claudia has shared with us about osteoporosis. Also, think about when you're doing your rotator cuff and pulling your neck back into position, right? Think about that. You do the rotator, right? There you go. There's one of them. We do the chin tuck, right? There you go. There's another one with the breathing technique. How can you apply this to everything that we do. Anybody have anything to offer in response? What they loved, what they learned? Anybody?
My daughter is fabulous.
Yay! Thank you so much.